these can do.
Mama,
Both of you do it. Easy one.
So which is the first drug madam told in her talk, no? Which drug you will give first? Oxytocin. What is the dosage? 10 units. That is normally. Suppose PPH, patient is bleeding more than the normal. That time how much you can give? How much you can give is 20 units you have to put in
500 ml of normal saline.
and then give it like around 60 drops per minute. The maximum dosage how much you can give is 60 units. Okay, because it will have other side effects. What will happen if you give more than 60 units? Urine output, it will be reduced, oliguria.
It is produced from the posterior pituitary.
Pituitary.
Extract. So it produces dilution, hyponatremia and oliguria.
Okay. After any doubts with you know how it acts? Through GCPA pathway, and it will cause what? Calcium channels it will activate and it will cause contraction of the smooth muscles of the uterus. So the next drug is misoprostol. So normally we use in labor room. How much we use misoprostol is what first? It is PGE1. Okay. So normally after delivery you have seen our PGs, no? They will put this tablet inside per rectum. 600 microgram. It comes in 200 microgram tablets. You put is 600 microgram. But during PPH, you can use up to 1000 microgram.
That's the maximum dosage you can get. Okay. Otherwise, if it's not controlled, you combine it with other drugs. But that is the maximum dose for misoprostol.
What are the common? Where else it is used? Misoprostol along for prophylactic for treatment. Then where else you use MTPs? Second and first trimester both. Along with combination of which drug? Can we give alone for this? We will combine it with some other drug. Which is that? Yes, very good. Mifepristone. You know, no? Then what are the common side effects of misoprostol? Fever and chills. Patient will start shivering or she will have fever. So you have to reassure the patient that this is because of side effect of misoprostol. Okay. Next, which drug we will come to? After this, oxytocin. Madam told no, oxytocin. This is the newer drug, carbitocin. It is analog of oxytocin. Same like mechanism of action is same.
Same except with the agonist properties.
But advantage is it can be kept at room temperature. Whereas oxytocin, how do you store? 2 to 4 degree in refrigerator. It should be kept, not in the freezer. So, but this carbitocin has the advantage. It can be kept. It is heat stable. Okay. Next, which drug madam told? Ergot alkaloid. That is methergine. Okay. Methergine also can be given. Where is methergine? This one. Okay. Some cases we avoid methergine. Which are those cases? PIH. We won't give.
Preeclampsia.
And RH negative pregnancy.
And especially if you are giving the patient other vasoconstrictor drugs like epinephrine, it is absolutely contraindicated. You should not give.
And RH isoimmunization. If mother form, IM we give or IV. IV we avoid, IM. But now recently ma'am told no, it is available only in tablets also. Like to maintain. For maintenance purpose, we can use tablets also. Okay. So now this is new addition for PPH management. What is tranexamic acid? Pharmacology. It is first line drug in all your AUB cases. Now what is the mechanism? Antifibrinolytic. Fibrinolysis means the fibrin clot will be broken down. Antifibrinolytic means it won't allow the clot to break down.
See,
so
this
this
DIC
is
of intrinsic extrinsic system. If fibrinolysis is supposed to be the cause of DIC, then your tranexamic acid will work very well. Now WHO has accepted it. It can be used both for prophylaxis as well as for the treatment of PPH. She will tell you the dosage.
Dosage is it comes in 500 mg ampule. Maximum is you can give up to 1 hour, 1 gram. After repeat doses after 8 hours.
8 hours.
We can't go on giving pause in tranexamic acid. 1 gram you can give and then repeat after 8 hours for maintenance.
This also has to be diluted in 100 ml of normal saline and given over 10 to 15 minutes. Direct IV bolus should not be given.
Are you all okay with these drugs, sir? Now, Dr. Preeti will teach you about uterine.
The bleeding which is happening from the uterine surface, that is from the inside endometrial surface. So right now we have two here. This is the Bakri balloon. Madam showed you many balloons. Okay, this is one type. This is the Bakri balloon. It's a ready-made balloon. So this has a tube, which is just like a catheter or a normal any tubes you have seen in the labor room, in an nasogastric tube or catheters, Nelaton catheters. Many catheters are there. This is a tube, and this is the balloon. Okay, and it is fixed here, and it has two outlets here. Okay, one is to inflate the balloon, other one any secretions which are happening or any collection which is happening from the uterus to drain outside.
So this
So
is
it
the
has two
advantage.
outlet. Advantage with this balloon. So what do you do
Suppose you
now?
put this balloon or a condom which were uterine cavity, the contraction of the uterus doesn't take place. So the very purpose of controlling PPH does not
The
happen. So
tamponade
that is the
doesn't happen
advantage
there.
with Becru balloon. You have an outlet, and similarly you have Sengsteken Blackmore tube, where you have two.
To insert it inside the uterus, uterine cavity. This has to go inside the uterine cavity till where you have to insert up to the fundus. So where you get the resistance up to there, you have to insert and you have to hold it in place. Only one person cannot do. You have to have another person who has to help you. The person who is inserting this bulb or
Last
this
2 minutes.
catheter inside the uterine cavity has to hold it in place, and the other person has to inflate the balloon. Inflating meaning it has to fill with water to stop the bleeding now. So either you take a bigger syringe, a 50 cc syringe. If another advantage, if you have a drip set and the IV fluid, you can directly connect the drip set to the outlet here. It will automatically fill. So how much you have to fill? Around 350 to 500 ml of water. So once you fill, the balloon is inflated. You have to check for the bleeding, whether the bleeding has stopped now. If still the patient is continuing to bleed, then you have to go for the next resort. If the bleeding has stopped, then you have to watch her for after some time. You have to again watch her for bleeding. And how long you have to keep the catheter in situ? Minimum of 24 hours. Minimum of 24 hours, you have to give the tamponade, and along with the tamponade, you have to give the medical management also. Only tamponade is not going to help. Tamponade is only going to compress the uterine surface, but uterus has to contract now. For that, you have to use the medical management. Along with this, you have to use this also, both. This is the readily available in the market. It is easy for us, but it is very costly. It is 6,000 to 800, 8,000 rupees. If the patient is affordable, okay, definitely you can buy and bring it. Otherwise, you can use the Foley's catheter, which is easily available in the hospital. This has to be done by yourself. This already has an artificial balloon is there. It is already fixed here. It is a very easy outlet is there. You just have to fill. But for this, it is not like that. You have to prepare your own catheter now. So you have to take a Foley's catheter, take a condom, open the condom completely and insert on the catheter. See, I have inserted now. Completely insert. Completely you open it up. Actually, I have tied it here because you have to tie it at the end. So at the end of the opening, this has to now balloon out, right? This condom has to balloon out. It has to sit like a balloon inside now. But it has an opening here. So what do? You have to close the outlet. So what do? You tie a thread very tightly so that the water will not leak. It should not leak. If it leaks, it will not cause any tamponade inside. So once you feel that it is like you have completely tied it, you have to insert this inside the uterus. Same like that only. You have to insert up to the fundus. One person has to hold it in place and other person has to inflate. Again, even Foley's catheter has two outlets. What are these two outlets for? There, one was to push the fluid, other was to drain whatever is collecting inside. But this here, this outlet is mainly to inflate the balloon which is there in the Foley's catheter. This is mainly for the Foley's catheter to sit inside the bladder. But here we are not using this outlet now. For us, this is the only purpose. Through this, where the urine will drain from the bladder, that outlet we are using. Same here, take the syringe and push it, or otherwise you can connect a direct drip set. Around 350 to 500, 350 to 400 is the maximum you can push, and then it has to sit inside. Once you feel that the bleeding has come down, you have to wait for another 24 hours. And the tensile strength of this balloon is very good. This is very less, so you have to be very careful. It might burst open. This might burst on its own. So carefully you have to inflate the balloon. ಹೇಳ್ದೆ ma'am.
Of PPH. Here we'll be demonstrating the different techniques of B-Lynch, then the modified B-Lynch, the Heman, that is the Heman suture, Chavos suture, and also the cervical tear. How to suture the cervical tear? Sponge holder in this constantly. Then with the other sponge holding forceps, you have to see for the, you hold it this position and see anything is there in this. Then you come here and then see there is a tear. So there is a cervical tear here. Similarly, you have to walk around the whole of the cervix circumferentially, clockwise direction, and then identify. So once you have identified your tear here, okay, so here you take the suture. Always, whenever any tear, you have to identify the apex. You go just 1 centimeter beyond the apex, so that there may be some vessels which are there which would have been retracted. If you don't include them, it may cause hematoma. Even in doing an episiotomy, we ask you to go 1 centimeter above the mucosa apex. Similarly, here also. So either you can take a like this, either you can take a stitch, simple stitch like this. Okay, simple stitch and then cut, madam.
Continuous suturing, how madam is doing.
Continuously you can go it, either locking or interlocking, non-locking. So if there is a bleeder, better to go with a locking suture. So unless you suture this, otherwise she will have a fish mouth appearance of this thing. In the next pregnancy, she may go in for preterm labor, or she may have a repeated infection, vaginal infection.
Complication of this thing that can happen.
See like this.
It is not alone to pain and relief. It can be used to hold the cervix also, and also the gravid cervix also. In case of DNCs, you can use it. So this is one of the practical important point that you should know. Okay.
Still she is bleeding from that. So then it is a surgical tamponade, what we are going to do. Here assistant will compress it like this, from above plus from here. So here we are going to take a suture. Here there are some 6 points you have to identify, which is 1 centimeter from the uterine wall here on either side. Okay, and then this is point A. Point A, 2 centimeter from the lower uterine segment. Take a bite here. Okay. Then go with the point B. This is point A and this is point. Just see point A and point B. Okay. Then you have to.
This is very important what madam told.
This is a B-link. So
back.
you have to come back.
And then
And here
posteriorly.
posterior wall. Posterior wall
level.
again I told you,
4
it is 4 centimeter from the edge of the lateral edge of the uterus here. And that is the insertion of your uterosacral ligaments. The attachment of the uterosacral ligaments. So you have to pierce
posteriorly.
here.
That is the
Posteriorly
point.
take this.
So that
point.
will be the point for you where you have
Come
to pierce.
anteriorly.
So you are going to come back and
come back here. Again, you have to take a transverse suture here, posterior wall. Then again from the posterior wall, come back anteriorly. Again same, 4 centimeter from this. Okay.
at the level of the uterosacral.
Uterosacral. See
Come
here.
back. Okay.
Got it?
And then you're
Next
bringing
your posterior wall, and then
similarly on the anterior wall, 4 centimeters away, one bite will be taken. Come back to the lower segment, tie the knot tightly. When you're tying the.
See now here you took now A and B. So that is C, D, E. This is the Okay, this is the modified Billy chart Heyman's Arul Kumaran's suture. Okay, next here. You are done with this thing. Lower segment is bleeding. Then what you can do is you can take this isthmocervical, isthmic area and cervix. Isthmocervical sutures like this.
Whatever the descending branches of the uterus are, that will
See here. Vessel you take at the I told near the lower uterine segment junction here in cesarean, if not here, try here it comes like this and goes at right angles. Ureter is here, bladder you would have pushed down. Take good bulk of the ಆಯ್ತಾ ಇರಲಿ ಪರವಾಗಿಲ್ಲ ಸಾಕು.
so whenever you are ligating the use an amount of pressure and thereby the blood will be taken care of. So one side you can see and watch whether the bleeding.
This is the uterine. In between, if you want, you can also put here in one more if you want. Otherwise, here again from this is the corner. You have ovarian vessel coming there at this corner. So include the ovarian. First take here. Say here, take the broad ligament, avascular area. Include this and then take a
You
stitch.
should be very careful in not including the vessel. Puncturing the vessel will be catastrophic.
So it is both artery and vein are occluded. So this is a stepwise devascularization. Okay.
Anticoagulant containing, and this they are going to allow it to settle for 30 minutes. Okay, in that 30 minutes, the plasma and RBC is going to separate. Okay, after that, they are going to clamp the one which is the PRBC, allow the one which is connected to this to go and separate the plasma from the PRBC. So then they are going to, I'll show a video. Then they are going to have a where they can separate the wire, right? Then you will get a separate PRBC and plasma. Okay. So this PRBC, once it is separated, what is the storage temperature? They want to keep it at 2 to 6 degrees. Now why is this? If they keep it less than 2 degrees, it gets frozen. The RBC is going to break down. If it is more than 6 degrees or more than 8 degrees, the bacterial growth also will be there. So the blood will get contaminated, gets infected, bacterial infections can occur. So this is the storage. 2 to 6 degrees is what is storage. How long can you keep this blood once you have donated? For almost 35 days. Okay. Now how much of this PRBC, one pack blood PRBC is going to improve your hemoglobin? 1 to 1.5 grams of the hemoglobin is what it is going to do. This is very important. Most commonly used is PRBC. Okay, kindly remember how much the hemoglobin is going to raise by this PRBC? 1 to 1.5. So usually they say whole blood is 0.75 to 1 gram. PRBC is 1.5. Okay. So then you can store this blood once donated up to 35 days. Store that freezer, blood freezer at refrigerator 2 to 6 degrees. Okay, clear in that? So next is, now you know the product. One is pattern. Remaining is plasma, platelets, frozen plasma, platelets, fibers. So now we are going to it is common for all the hemorrhage. So first, before we are arranging blood, we will start giving steroids and colloids. So that our volume gets replaced. Again, it might cause dilution of coagulopathy, first point. Because of massive hemorrhage, again should the volume to the DIC. So now what two components are to come? One is blood loss and she is going into coagulation problem. Invariantly, the death happens is because of both volume replacement, volume depletion plus coagulation problem. So whenever a massive hemorrhage happens, alone transfusing blood is not sufficient. As you have seen in newspaper, they will tell 32 blood we gave, still patient couldn't survive. That 32 blood includes everything what they have got. So modern will tell now what are the indications of cryo, what are the indications of platelets, and what are the indications of FFP. Okay, so now I have ordered blood. So now she is bleeding. So we have started two IV cannula. One oxytocin, our oxytocin is going on. One we have started blood. Next, what I will order now for at least from 4 pills to 4 pills, we have to order FFP and platelet count if it is less than 1 lakh platelet. And if you have fibrinogen and D dimer changes, then cryoprecipitation. Very simple. So, what do you think? All this lab, all this, whenever it is happening, it is not like everything is not confidential. It can happen in our nursing home. My lab technician won't be there at that time. So, even getting blood investigation also becomes this way. So, as a protocol, whenever a PPH happens, just waiting for reports, we start transfusing the blood then blood products. It is not just blood then blood products.
But previously, how much to give was different. The concepts now is different. How much charges here we need, how much effective we should be, how much cryo we should be. It is now 1:1. If you give one pint of here is one pouch, then one energy. One cryo. The ratio now is previously it used to be 4:1. I think in one of the slides I saw 4:1. But now the change guidelines are 1:1:1.
What coagulation problem? So
You
here what you
remember
know,
that.
thinking it is
You don't overwrite like previous because the guidelines keep changing. You should be updating. So 1:1.
See, one more point that you got to tell is now you've got the blood. See, as in interns, you're all upcoming going to be in interns also. So when do you start? When do you stop? So once you got the blood, within 30 minutes of getting from the blood bank, you should have started it and finish it within 4 hours. Okay. So cryo and platelets, how we are going to give, how much is going to use. Okay. If the cryo is basically it's containing the coagulation factors, right? So it is going to improve by 5 to 10% of the fibrinogen. Okay. So you're going to get the four units of this cryo. Okay. Platelets, it is into two things: single donor platelet and multi donor platelet. If it is multi donor from all the blood, multiple, some 4 to 6 blood of the PRBC of the whole blood, you're going to collect this platelet.
Can't open your
Okay. So that one, it is going to increase by almost 7 to 8,000 of platelets. But if it is from a single donor, okay, the platelet is going to raise to even 30,000. Okay. So that is very costly. Okay, it takes time to prepare that platelet because it like that only for 30 minutes so that the PRBC is settled and the plasma is also separated. Okay, how do we get this separated? Or they can, with a soft spin, also they can separate this PRBC and plasma separately. Or if not the soft spin, they can just keep the blood like that. Wait, pause. Illi first. Blood, right? You can see here. You can see here. They'll keep the blood and allow it to settle into, separate into the PRBCs and plasma. So one that is there settled, you can do a soft spin over here. Right, see here, this is almost 55% of the plasma and 40% of this PRBC is there, right? So this is how, you connect, separate the two bags. Play the video, no, Preeti? In this video, you can see where the blood and the PRBCs and plasma is separated, right? It is going to the one more bag, right? Can you see here? Separation. Full screen, eh? Yes, and then they're going to seal this bag separately and then keep it as PRBCs and fresh frozen plasma. Now coming to the PRBCs.
Pouches you should be able. PRBC ಇದಲ್ಲ
ಇದೆ pouches.
So identify the pouches
ಇದ
correctly. How do you? What is the color of?
ಎಕ್ಸಿಟ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ ನಾನು. ಏನ್ ಸಾಕು ವಿಡಿಯೋ.
Obviously, it's going to be red, right?
Show the
You should know
PRBCs.
by if you hand
Yes.
over 3 pouches, you should be able to identify this is PRBC, this is a fresh frozen plasma, and this is platelet, and this is cryoprecipitate. So the quantity will be 350.
So yes,
350 ml in each.
250
red
to
color.
350.
And
330
you will
actually.
have to order. It would have been, as madam said, prepared and kept it in the blood bank. Now you have to raise the request, send a request for the required patient? How do you assess? How do you know that she needs blood transfusion? You know, she is bleeding, she is in shock,
So it becomes
is the patient of
hypotensive,
PPH, or anticipating that she is going to bleed, we
like
keep them
placenta previa,
reserved. So
abruptio.
reserve the blood, and then how much, on an average, approximately we keep blood enough to raise the hemoglobin to expected around 10 gram per cent. So deficit, we should know if she's 6 grams, we need to reserve at least 4 pints of blood, because one pint of one pouch of PRBC will raise by 1 gram approximately, or 1 to 1.5 gram. Accordingly, we should keep those many pouches of blood ready. Once we receive, you should check the
The
identity
labels
of the
has to
patient,
be
IP
cross-checked.
number, name, and the blood group. So you should check these details before you start transfusion and take the consent. To transfuse any of these blood, whole blood, or PRBC or components, you have to get the consent, and cross matching is mandatory. So after that, you will transfuse, taking precautions to keep the drugs ready for
Transfusion reaction.
transfusion reactions. So you've seen the blood transfusion procedure done in the wards. We'll be doing that when you
Giving
become an
donation. Okay.
intern.
Yeah, yeah. As an
So
intern, you will be doing that
doing that,
not only in
monitoring the
our department, in
vitals,
every department.
document the
Mhm.
time of starting and the time of the closure, and one pouch
So
of
even the
blood should not
vitals.
last more than 4 hours. And once you receive from blood bank, it should be kept in room temperature not more than 30 minutes, so that it doesn't become heated up, and the hemolysis should not happen. Within half an hour, you start the transfusion and finish within 4 hours.
Within 4 hours.
Understand? And meantime, observe for the any signs of anaphylaxis. What are the signs? How do you know that she's going for transfer?
There's
You would have
reaction is
not
happening.
know so
How
much.
do you know the reaction is happening? That is what madam is asking.
Patient will have fever, chills, and she may develop rashes. She may have
Hypotensive. She
hematuria. You
can
would have
become
read or
hypotensive.
learned about all those, no, blood transfusion. So any of these, if you find stop transfusion, start a plain fluid and give anaphylactic drugs for treatment of anaphylactic. What are the drugs for anaphylaxis?
Hmm. Or
Hydrocortisone,
hydrocortisone. And
antihistamine, and then adrenaline, IV fluids,
if this hypotensive.
aminophylline, oxygen, all these we should keep it ready when you
Okay.
start transfusion. Anticipating reaction to any patient, we should keep all these drugs by the side of the patient. Okay.
So then coming to the spoken to you about the packed RBCs, the whole PRBCs. Right. Next is what we are going to transfuse the plasmas. In the plasma again there is fresh frozen plasma, there is cryoprecipitate, and there is platelets. Okay, these three things. When do you give? How do you give? How much do you give? Okay. So fresh frozen plasma again, as we said, within 6 hours of collection of the blood is what is this fresh frozen plasma. You deep freeze it at minus 65 degrees and then again store it at minus 25 degrees. Whenever you want to use it, you're going to thaw it, okay, for almost 20 to 30 minutes and then going to use it on the patient. After thawing, within 6 hours of thawing, you have to finish this. You have to invariably use it or discard it if it is not used. Okay, so for how much is the fresh frozen plasma volume? Almost 200 ml to 220 ml for fresh frozen plasma in each unit of the bag, right? And you can store this in minus 25 degrees, as I said, for almost a year. Whereas PRBCs you can store only for 35 days. Okay, fresh frozen plasma, cryoprecipitate, you can store for 1 year. Okay, so when do you give? You thaw it within 30 minutes and immediately you give it. Within 30 minutes of starting of this transfusion, it has to get over. Now, what are the indication? Whenever the patient is having bleeding, excessive bleeding, she's already lost the blood. Along with blood, she'll also lose the clotting factors. Right? Not only blood, she'll also lose the clotting factors. So to get the blood into the clotting, you have to stop the blood. You need to give the coagulation factors. Right? You have to correct that mechanism also. So what contains in this plasma is the coagulation factors. Right? So you have to replace the coagulation factor by giving the fresh frozen plasma. See, it can be single clotting factor deficiency or multiple clotting factor deficiency, especially in DICs, right? Or massive transfusion, or whenever there is warfarin overdose. The patient has come, she was taking warfarin, she's asked to take immediately.
emergency section, but she is on warfarin. You know the bleeding, the chances of bleeding is there. So whenever that is the risk is there, immediately you can give this fresh frozen plasma to counteract the warfarin overdose too. Okay. So one is hemorrhage, then platelet. Whenever the platelet goes less than 20 is where we transfuse the platelet. But in case of a massive hemorrhage, guys, massive PPH is happening, the platelet drops down to 50,000 itself, you're going to start this platelet transfusion. In platelet also, you have two varieties, single donor platelet and multi-donor platelet. Multi-donor, you take it from 4 to 6 blood, right? Whenever the patient is donating or the donor, the volunteer is donating the blood, from 4 to 6 units of this blood, you want to collect it and give. So for each unit of the platelets, which I said, the platelet is going to raise to 8,000. But from a single donor, you collect extract by apheresis, you're going to raise the platelets by almost 30,000. From single donor, you raise the platelet by 30,000. From multi-donor, only 8,000. Okay. So where you give whenever there is low platelets, thrombocytopenia. Okay. Right?
This is non-pneumatic anti-shock garment. Okay? The mechanism by which it acts is mechanical pressure over the lower limbs and the abdomen so that the blood is supplied to the vital organs like heart, brain, okay, and blood is pushed upwards. The blood supply to the uterus is reduced, so the bleeding also comes down. Okay, so this is used to buy time to shift a patient to a tertiary care center. Okay. So this method is not used alone, it can be used along with other methods. It's an adjunct to other methods, like your oxytocics can go along with this. Okay, so how do we use this? This segment 1, 2, 3 is for the legs, 1 is for the ankle, 2 is for the calf, 3 is for the thighs, okay, 4th is for the pelvis, segment 5 and 6 is for the abdomen, okay. And this position here, there is a ball, you can see this has to come over the umbilicus area, over the uterus, okay. So this you have to see first one, okay. So you start with 1, okay, 1 you tie, so can you come and tell me? Yeah. 1 you put it like this, okay, so it acts by velcro. Similarly the other leg, next she'll come to the segment 2, she will tie over the calf. After that is done, she will come over the thighs, that is the segment 3. So after putting the segment 2 and 3, you see that there is space between for the knees so that she can move her legs, okay. And then you place the segment 4, which is over the pelvis. So it should be sufficiently tight enough to give pressure. And then she'll place the segment 5. This 5 will come over the uterus, umbilicus, okay. And then the 6th segment. So then this will sit over the uterus and give mechanical pressure. So either at this time you can shift her to the tertiary center, or if you're monitoring here only, you have to monitor the vitals, pulse, blood pressure, IV fluids, oxytocin. Everything has to be given. Okay. You continue. So after you at least observe her for 2 hours. The pulse, blood pressure is maintained, pulse less than 100 and BP is okay, then you can start removing with the first segment. Okay, then you can start removing the first segment. One you remove. Wait, one you remove. After that you see for wait for 15 minutes, and 15 minutes there's no drop in pulse. Pulse is less than 100. BP systolic is not fallen less than 20.
The same way you have applied, same way you have to remove. But hemodynamics is very important. Okay?
After 15
Simply
minutes,
just because half an hour is over, you should not remove it.
after 15 minutes, you remove the segment 2. Again wait for 15 minutes, check for the pulse, BP, same thing. Then segment 3. Okay, again after 15 minutes, segment 4. In between, in any case, if there is drop in the pulse, okay, if there is increase in the pulse more than 100 and systolic blood pressure drops to less than 20 of the previous, then you have to stop, you have to wait, okay. And this can be easily washed, okay, and can be used for the next patient, okay. Now how do we store it? Okay, same thing, you close this like this, 1, close it like this, 1. After that, this is to be folded inside, okay. Now she'll close segment 2. After that she will close segment 3 one by one. Okay. Next we'll fold it like this. Okay. Then we close the segment 4. Close the segment 4 also.
How long can we keep this for?
So you can keep not more than 24 hours. Okay. Either you shift if you're not able to do, or to see if it is improving. Otherwise you have to shift her for better methods. Okay. Then close this and store it for ready for next use. Okay. So thank you. Putting it and similar way you remove it. So this is for the pressure. This is because there is, you just put, this is a velcro thing, so just the pressure is there. Okay, there is no air in between, just the tight pressure. Okay, so that's why it's called like that. So this portion will sit on the uterus and give compression. Okay, if you feel while you remove in between these two there is any drop in the BP, systolic less than 20 difference, okay, and pulse drops less than 100, then you have to again tie it back. Okay, and wait. And meanwhile IV fluid should go. Meanwhile you have to you can check for the vaginal bleeding also. Okay, and after putting this you should ask the patient whether they are able to breathe comfortably. Okay, then it is
to show the students whenever the PPH occurs, what are the basic things they have to do, preliminary, what are the initial drugs they have to administer, and how to transfer a patient to a tertiary care hospital. What are the indications, what should be the hemodynamic changes before they transfer the patient to a tertiary care hospital. In the tertiary care hospital, whether admission has to be done to the ICU, a consent has to be taken, whether medical or surgical management depends on the tertiary care and the general condition of the patient. Okay, so depending on that, we explain to them and we counsel them whether it is medical management or surgical management. Depending on that, we manage them in the RRMCH.
Placenta is delivered. Placenta is delivered. Dr. Meghna, can you please check the uterus is not contracted well? Can you please check it once? Ma'am. Yes, ma'am. Patient is bleeding gushes. Dr. Kranti calls for help. Yes, ma'am. Dr. Likita, please come. There is a patient who is bleeding heavily. Dr. Likita, this is Aishwarya, G4P3L3. She came, she delivered. Placenta is out. Patient is bleeding gushes. Aishwarya, Aramagirira. Aishwarya. Patient is drowsy. Go activate code H. Yeah. Please activate code H. Anusha, please come. There is a need help in labor room. Dr. Anusha, please check a pulse and BP. Uterus is soft until the umbilicus. Dr. Kranti, can you please check for pallor and respiratory rate? Yeah. Aishwarya Nalak Torsi. Aishwarya Nalak Torsi Swalba. Kantorsi. Patient looks paler, Dr. Meghana, and respiratory rate is 33 CPM. I removed it also. Keep it aside. BP is 90 by 50. Pulse is 132 beats per minute. Patient is bleeding. Dr.
SpO2.
Anusha, insert 2 white bore cannulas in both arms. Draw samples for CBC, cross matching, blood grouping, VTCT from one hand. In the other one, start a running drip of RL.
I'll put the plaster. I'll take this one. RL. No.
She's still bleeding, which is pink. 16, which is grey in color.
Gray. Green. This is 20.
Two IV lines, one on this side and ideally then divided four sides.
Starting an RL drip. Dr. Kranti, can you please connect 20 units oxytocin in one drip? Yes.
She will be still massaging and doing a bilateral compression.
20 units oxytocin added in 1 pint RL, 500 ml RL, 60 drops per minute is going on. Keep the tonics ready. Dr. Likita, can you please help me catheterizing the patient?
जब हम कैथेटर को यूरेथ्रल ओपनिंग में इंसर्ट करेंगे तो वो इंजर्ड ना करे, फ्रिक्शन से जो है इंजरी हो सकती है। एक स्ट्राइल किडनी बेसिन को महिला के दोनों पैरों के बीच में रखना है। कैथेटर का ओपन जो इंड है वो किडनी बेसिन में रखना है। एक हाथ की सहायता से लेबिया को अलग किया जाएगा और दूसरी हाथ से जो कैथेटर है उसको यूरेथ्रल ओपनिंग में डालेंगे। तब तक डालेंगे जब तक कि यूरिन जो है
And one thing we need to do then and one thing we need to do then is retract. It's helpful to have some assistance for retraction. You don't want too much retraction, just a little bit. So we now see the uterine cervix. After delivery, it looks rather ragged, and you have difficulty finding where is really a tear and where is it just ragged. So you grab it with a sponge forceps. You look, no tear there. So you walk around the cervix. No tear there yet. Seems there's something going high there. You've walked around the cervix and you've found a tear. So there you have identified the tear. Like with the vaginal
Placental examination. Placenta looks complete. Placenta is complete, but uterus is still soft. Let's start second line uterotonics. Dr. Kranti, please give tab misoprostol 800 microgram sublingual. Yes. Give per rectal. And Dr. Anusha, please give injection prostaglandin 250 micrograms and give IR. Just to uterine. Per rectal misoprostol is given.
Patient is still bleeding now.
Doctor, Dr. Anusha, can you please keep injection tranexamic acid ready in case we need to use it? Patient is still bleeding, uterus is still soft. We'll do bimanual uterine compression.
Insert a cupped hand into the vagina and form a fist in the anterior fornix. With the left hand on the patient's abdomen, compress the uterus between the two hands to compress the bleeding placental bed. Maintain compression until bleeding is controlled and the uterus contracts.
Dr. Kranti, can you please see if the ambulance is ready? And also, can you counsel the attenders in need of referral and to arrange blood donors? Okay, no, bleeding has stopped. No bleeding? No bleeding. Cloth again.
still ಅವಕ್ಕೆ ಇನ್ನೂ ಬ್ಲಡ್ ಅದರ ಹಾಕ್ಸ್ಬೇಕಾಗುತ್ತೆ. ಅದು ದೊಡ್ಡ ಹಾಸ್ಪಿಟಲ್ ರಾಜರಾಜೇಶ್ವರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಅವೈಲಬಿಲಿಟಿ ಇದೆ, ನಾವು ಕೇಳಿದ್ವಿ. ಅಲ್ಲಿ ಫ್ರೀ ಸಿಗುತ್ತೆ, ಎಲ್ಲ ನಿಮಗೆ ಅರೇಂಜ್ ಮಾಡಿರ್ತಾರೆ. ಸೊ ಅಲ್ಲಿ ಹೋಗ್ಬಿಟ್ಟು ನೀವು ಮೆಡಿಕಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ಗೆ ಬ್ಲಡ್ ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ಗೆ ಎಲ್ಲ ಅಲ್ಲಿ ಹೋಗ್ಬಿಟ್ಟು ನಾವು ರಿಫರ್ ಮಾಡ್ತೀವಿ. ದುಡ್ಡು ಏನು ಬೇಕಾಗಿಲ್ಲ, ಅವರೆಲ್ಲ ಫ್ರೀ ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ಸೊ ಅಲ್ಲಿ ಹೋಗ್ಬಿಟ್ಟು ನೀವು ಮ್ಯಾನೇಜ್ ಮಾಡ್ತೀವಿ. ಓಕೆ, patient is already in rrmch now.
No, ma'am. Dr. Anusha, please make sure you accompany the patient in the ambulance to RRMCH. Please keep a referral letter ready. Mention all the drugs that we have given with the date and time. Accompany the patient. Make sure the oxytocin drip is going on. Monitor pulse and BP every 10 minutes. Is the ambulance ready?
Yes, doctor. Ambulance is ready.
Please inform us when the patients reach the hospital. Aishwarya, ಆರಾಮಿದ್ದೀರಾ? ಬಂದಾಗ ತುಂಬಾ ಬ್ಲೀಡಿಂಗ್ ಆಗ್ತಾ ಇತ್ತು, ಡೆಲಿವರಿ ಆದ ನಂತರ ಜಾಸ್ತಿ ರಕ್ತ ಹೋಗಿದೆ ಆಯ್ತಾ, ದೊಡ್ಡ ಆಸ್ಪತ್ರೆಗೆ ಇವಾಗ ರೆಫರ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ.
Important thing is how long do you wait?